Dear all, hello. I would like to welcome you to the 21st Journal Club of the European Journal of Cardiovascular Nursing. I am Ekaterini Lambrinou. I am an associate professor in the Department of Nursing of the Cyprus University of Technology. And today I'm very happy to moderate a discussion on a recent paper with the first author of the paper entitled Trends in Time in the Management of the Implantable Cardioverter Defibrillator in the Last Phase of Life, a retrospective study of medical records. And here with us is our first author, and I would like very much to introduce yourself. Welcome, Rik.
Thank you very much. So first of all, thank you very much for the opportunity to discuss the results of our paper here today. Well, it's very nice that you think the study is interesting enough to also discuss the results here. So I'm very, very glad about that. My name is Rik Stoevelaar. I work in the Erasmus Medical Center in the Netherlands. I'm a psychologist, and I'm currently working on my PhD here on indeed the implantable cardioverter defibrillator in the last phase of life. Yes.
Glad to have you with us. Rik, I would like to tell us, first of all, which were your motives for undertaking this research?
Yes, that's a good first question. Well, it started like the ICD, the implantable cardioverter defibrillator. It's a very effective machine to terminate life-threatening cardiac arrhythmias. But when death is imminent due to, for instance, terminal illness, a deterioration of your underlying heart disease, or older age, shocks might be unwanted and might be a factor of distress for the patient and the family as well. Like a recent integrative review also showed that a very large amount of patients actually still experience shocks during their last days of life. These shocks are painful, but what we saw in those studies was that the studies were generally older, were relatively small, and were predominantly in patients who had their ICD for secondary prevention. And nowadays we see that patients often get their ICD for primary prevention. So that made us think, and also due to all the recent developments in the field of cardiology and the field of ICD management, with, amongst others, the publication of numerous guidelines on ICD management, but also the further optimization of ICD programming. That made us think about whether those numbers that were being presented in those papers are still relevant today, and whether the problem which was described back then is still in current research and in current practice, whether that's still the case that those patients are getting painful shocks. And that's actually why we started this research. We retrospectively examined a sample of 380 patients in medical records here in the Erasmus MC, and also in a hospital, a general hospital in which we collaborate as well. And we decided we wanted to have a look at the trends in time of, amongst others, patients receiving shocks of their ICD, ICD deactivation discussions, and deactivation of the ICD. So we wanted to see whether there was an increase in deactivations, whether there was a decrease in shock incidents, and whether they're discussing the topic of the last phase of life. So that's what we examined. I don't know, should I already tell you something about the results of that study as well, what we found?
What I would like to ask you first about your study design is, how did you choose the particular hospitals? Are they representative for the population of this kind of patients? Mm-hmm. How did you choose those registries to collect data?
Mm-hmm. Yeah, well, here in our hospital, Erasmus Medical Center, we are a university hospital, so an academic hospital, and because like generally the patients that are here, they are a good representative sample of the population we have here back in Rotterdam. But since we also wanted to see whether patients in a general hospital, which might have other problems, have the same problems in this field. We wanted to also include the general hospital as well. So we have two hospitals, one general and one university medical center, and those two combined give a very nice representative sample of how we're dealing with this problem in the Netherlands here, or at least in the area here. Yeah.
And I have another question on your methods. It's about the data analysis. As I noticed, you separated in 3 times your investigation from 2007 to 2009, 2010 to 2012, and 2013 and 2016.
Yeah.
Why did you separate at the time like that? Is there a reason for that?
There is a reason. Like the first ICD implantation here in our hospital was back in 1998. And well, during the years after that, there were being more and more ICDs being implanted by the cardiologists here in our hospital. And what we saw is that the patients and also the medical records of the patients were very good to be examined from of 2007. And what we decided to do, because we really wanted to see those trends in time, and from, I think, 2006, we saw a switch in the indication for implantation from secondary to primary. So that was our starting point. So patients who died from of 2007. And then we basically just evenly divided the time till 2016, because we did this research a year ago, and up to 2016, our medical records were fully complete. So that's the time period that we had, 2007 to 2016, and then we just evenly divided those in their separate time periods. Yeah.
Okay, so the results were as you expected them to be? What did they show?
I think they were what we expected them to be. So we basically had 3 main things that we looked at. We had the discussions about the ICD deactivation, and we did expect an increase in those ICD deactivation discussions over the years, amongst others, because there's more attention on the topic of the end of life as well. Especially here in the Netherlands, we have a very open culture of talking about topics about the last phase of life, about the end of life. So that's the first thing we looked at, those ICD deactivation discussions. Then the ICD shocks, we expected a decrease in those shocks, also amongst others because of the developments in ICD technique, with longer detection rates, other cutoffs. So we really expected a decrease in those. And then the deactivation, so the act of deactivating the ICD, we also expected that to increase over the years. Also because there's more attention, because they're talking about it more in the consultation room. So we expected an increase in that as well. And that is also what we found in the results in our paper, that like the increases and the decreases were as we expected them to be. Yeah.
Nevertheless, I noticed that still the discussion, especially before implementation, is not quite often.
Yeah.
And as I see it's done differently in several hospitals and settings. So I would like to know, do all hospitals have the same person for discussing the deactivation? Even the same hospital, was it the same person? Did they follow a protocol? And who actually did? I see you have some details, but in some point, especially for the pre-discussion, it's not very clear who has done that.
Yeah, well, the pre-implantation discussion, and that is quite new to that extent, that hospitals in the Netherlands, or at least hospitals like our hospital and the other hospital that we participated with, Before implantation of the ICD, all patients have a pre-implantation discussion, which is being done by an ICD nurse. So that is a nurse who does not only talk about the end of life, that's just a small bit of the conversation before implantation, but the main part of that discussion, of that conversation with the patient, is about practical matters. It's about the operation that's going to happen, like the surgery. It's about questions that the patients have about that surgery, about the lifestyle implications, about what they need to do when they receive a shock of their ICD. And very briefly, deactivation is being talked about in that first conversation. So that conversation is being done by the nurse, and then what you basically have is a very large follow-up phase, because like from the moment a patient gets their ICD till the moment that they might be in their last phase of life, there could be like years and years between those 2 points. Of course, you have the battery of the ICD that might become end of life, so a new battery needs to be installed, a new ICD needs to be installed. Then obviously they're gonna again have a look at the indications of the ICD. So then they're again gonna have that talk. And at the end of the disease trajectory, so when there is a deterioration apparent, when someone gets in the end of life, then they're talking more in detail about deactivating the ICD. But as far as responsibility, because that's a large part of this, there isn't one person fully responsible for that conversation. There's not, we didn't say, all right, you have to do this conversation or you have to do this conversation. And that's also what we saw in our study, that some of the conversations were being held by the cardiologist, some by the ICD nurse, some actually by the general practitioner. So there's a lot of different healthcare professionals who are talking to their patients about this topic. So there isn't really one person that nowadays has these conversations with the patients. And that's, I think, also something which needs to be maybe more fine-tuned, so that really the responsibility of informing the patient, not only about the medical information, but also about a lifestyle and the implications that an ICD has on the life of the patient. I think that might be more fine-tuned, that one healthcare professional becomes responsible for talking to the patient about that. And I think the nurse is a very, very good option to have those conversations, yes.
But we do have qualitative research that they refer that they are not actually ready for such conversations. They find it quite difficult. And I'm not quite sure that the team, the health professionals that collaborate together to discuss this kind of things and to say we have to make this conversation and we need to do it this way, so this will be easier for each person to know what to say and when. Do you think, as a psychologist as well, this is important, and how do you think best they could be prepared for that?
Yeah, I think you're right. Research shows that also some healthcare professionals experience barriers towards discussing topics like this. And I think that might be both due to experience and both through education as well. As far as experience, like of course, healthcare professionals, especially also in cardiology, they focus on treating the disease mainly. A patient comes in with a certain problem, and they're going to look at how they can overcome that problem for the patient. And that's how also they're being educated. And I think those barriers that they see, they are very real. They are also sometimes difficult to overcome as well. But I think education is actually the main source of how we can overcome these barriers. So the healthcare professionals should receive education, also mainly to be aware of the implications of what an active ICD might have in the last phase of life. And I think when there's more awareness about the problems that it has, I think that might also might give like a new conversation between the healthcare professionals to think about, hey, like how we do it right now. Should we try to have a different approach? Should we make a checklist to have it? Should we have a, for instance, a 5 annual conversation about living with the ICD with the patient? And I think the awareness of the implication of that ICD at the last phase of life, I think that's the most, maybe the most important thing to do right now. And that's, I think, what we, what might be the best thing to do at the moment.
And I think this is the point I would like to highlight, the importance of the different health professionals, that they should collaborate together. Like you're a psychologist, maybe you can introduce us to be actually helpful in our clinical setting and practice. And so we are very happy to have allied professionals with us, collaborating more with us the latest years. Before coming to a little before the end, I would like to ask you, were there any missing data that you had looking on the registries, and were any information that you would like to know that it was a bit do that, maybe because when the researchers started collecting this data, haven't thought in mind, like, for example, the educational background of the patients, that is important when we need to educate them and talk to them for difficult things. What would you like to say about that?
Yeah, I think, like as with any, I think, medical record study, medical records are usually, they focus on the medical part. That's why they call it a medical record, obviously. There were missing data considering, for instance, educational background. We didn't have data about that because that wasn't in the medical record of the of our hospitals. We do have a very extensive database, which is actually being held by one of the co-authors on this paper, Dr. Teuns. And he really puts in everything we know about these patients in that database. For instance, about clinical indicators and stuff like that. But I think, and that's also something that we saw, that about half of the patients in our study actually die within our hospital. The other half either dies at home, dies in other care facilities, or there was also a part of patients that we actually didn't know where they died. We tried to overcome that missing data to also call up all the GPs of the patients that didn't die in our hospital. And what was actually very interesting is that while some GPs, they could provide us with the information that we needed, but there also was a base of GPs that actually didn't know as well. They said, well, last time I saw this patient is 2 months before he deceased. And in those 2 months, we never heard of that person again. So that is very difficult from medical record studies, that there's always going to be data that is not in those medical records. And that's also something about the medical records as well, is that when we have a conversation with a patient, it's almost impossible to write down everything in the medical record that we talked about. It's impossible because
maybe that is sometimes very useful to include the nursing history that we take, or other professionals that they take into consideration a more holistic approach. You also discuss, and before closing, a few difficult terms like DNR, euthanasia, that is actually a Greek word. And especially in there are still countries in Europe that the law does not allow this kind of decisions. So health professionals is in a very difficult condition in making these decisions. So you can imagine how difficult it is to discuss it and even aware the family and the person about this condition. What would you suggest as a global proposal for this kind of conditions, because this is a therapy that is now in our clinic, in every country clinical practice.
Yeah, well, I think you're giving a good example of the DNRs, of the do not resuscitate orders. Like we here in the Netherlands, we are a pretty open culture about talking about end of life, about euthanasia, about DNR. So that's definitely something that might be different in other countries as well. And what I do think is that the DNR, like the DNR order in itself, that it's just an outcome of the conversation that you have with your patient. I think what's most important is the process of advanced care planning, of ACP, which is thinking about the end of life, talking about the end of life with the healthcare professionals. And then as a possibility, writing that down in, for instance, or a DNR order or in an advanced directive. But I really think that the conversation you have with the patients about their goals and preferences of care, I think that's the most important starting point to do. And the DNR, of course, it is important, but it is an outcome of that conversation. And I think the conversation with the patient, the holistic approach of the patient, I think that's the most important thing to have.
Great. I think this is a great conclusion of your paper, Rik. Before ending this, I would like you to tell me what is your plans? How will you move forward with your results and the findings that you have? What is your plans right now? Yeah. What shall we expect?
What should we expect? Well, we do have, because this paper was part of a larger project on ICD in the last phase of life. We are writing other papers at the moment, also focus groups with patients, with bereaved relatives, with healthcare professionals as well. And I think for the future that it is most important to come up with educational programs to raise the awareness amongst healthcare professionals about this topic. And there were very interesting small studies already that showed that with a very easy and short and easy to implement program, you can have really amazing results of discussion rates going up to 100%, no more patients dying needlessly with unwanted shocks. So I think that the education part is definitely something that we will focus on in the next couple of years, yes.
Thank you, Rik. Thank you for your explanations and suggestions. And please submit more papers in the Journal of Cardiovascular Nursing. And hope everybody you have enjoyed these discussions that we had today, and looking forward for the next articles to be discussed with you. Bye.
Thank you very much. Thank you.